G'day, I'm Jeff. I'm the Monash Children's Hospital MRI Supervisor, and today I'm going to talk about paediatric MRI imaging at 3 Tesla. So I've been a dedicated paediatric radiographer for the last probably around 10 years or so, and more specifically being a paediatric MRI supervisor at the new Children's Hospital, Monash Children's Hospital, for the last nearly 4 years. So our philosophy at Monash Children's Hospital has always been obviously patient care first, and just bringing the best experience for them. Once again, I have such an important role. We have such an important role to make that medical journey for even newborns to teenagers, to make that first experience that much better for them. And it's a challenging role as a hospital, but having a brand new hospital gives a new lease or a new experience for them, and making that journey much for the family as well. And obviously, in medicine, there's always new ways and innovations coming through, and we need to be on top of that, and we need to innovate through working with vendors that are innovative and bring that new innovation, new technology, and bring the best healthcare to life in a clinical setting for all the paediatric patients and in need. So some of the main challenges scanning at 3 Tesla for paediatric imaging is your B1 and B0 and B1 homogeneity issues. You have dielectric effect issues, and with the increased RF power and deposition, you can have increased SAR issues as well. And with the longer T1 time in tissues, and that can cause a bit of signal loss and contrast problems, especially in neonates, since they have a high water content in the brain. And you can get increased chemical shift artifact as well, which requires altering of the bandwidth, which can reduce your signal as well. With the increased SAR issue, more importantly, this can lead to longer scan time and increased heating in the patient, which brings discomfort. And this is all a major challenge for pediatric patients, because once discomfort sets in, they're not going to keep still. A longer scan time, they're not going to keep still. So that all ends up being a major challenge in MRI scanning. With the increased chemical shift artifact, you can get some black banding around some of the organs and tissues that you may look around, and this brings in artifact and can be misdiagnosed at times, as well as the B1 homogeneity issues that can cause some black banding and loss of signal issues throughout the area we're looking at. You can get these black darker spots throughout the region of interest, and that can be quite problematic, and which also leads to image quality problems and diagnostic problems for the radiologists. With the increased B0 in homogeneity, you can have fat saturation failures or just increased distortion, which makes the image quality poorer, and once again you can have misdiagnosis and have a longer examination time as well, which is not favourable for paediatric MRI imaging once again. Compressed Sense has been an amazing tool to use. It has increased image quality while reducing the scan time, and further reduces the SAR, which has been one of the major problems at 3T. Now, to combat T1, longer T1 times at 3T, having parallel imaging and compressed sense on board, which has been amazing, because the increased signal can reduce the scan time, and bringing more contrast, bringing more resolution, and changing the parameters can alter the signal. So having that extra signal to play with has been a game changer, especially at 3T scanning neonates. Although longer T1 has always been a problematic at 3T, but there's always light in the tunnel. There's always advantages with a longer T1 as well, especially in 3T. MRAs with better background suppression and with the extra signal, with compressed sense and parallel imaging, you can make the MRIs much quicker and for a historically long sequence, you can reduce that scan time, which is ideal for the pediatric population. With contrast MRI, this further enhances the T1 contrast as well. And with contrast studies, you can have reduced voxel size, have better resolution, or you can have a better temporal resolution in dynamic contrast MRI scans like 4D track, and can show the AVM much clearer and giving that dynamic details that the radiologists need. With longer T1 time, the ASL has nearly 3 or 4 times extra signal, and with that extra signal, it gives benefits for, especially in pediatric population, who might be afraid of needles, and this can give them contrast-free perfusion imaging. B0 inhomogeneity has always been an issue at 3 Tesla, and having M-Dixon on board has been a game changer, especially dealing with difficult areas such as temporal bones, neck and head, and in small extremity areas where there's bone and tissue interface, and fat saturation failure has been a thing of the past.